Hi, I'm Dr. Asit Arora. I'm the Director of GI and HPB Oncosurgery at Max Super Speciality Hospital, Saket, New Delhi. So colon and rectum basically is the distalmost part of the intestine. They are also called as large intestine because of their diameter. So they are bigger in diameter as compared to small intestine. Lengthwise, it is about 2 to 3 meters in length. So colorectal cancer is the cancer that arises from the inner layer of the colon and rectum. It is one of the commonest cancer in the human body. It's probably the third common. It amounts to the second most common cause of cancer-related death in the world. Now its incidence is unfortunately increasing in India, and it's already one of the leading causes of death in India too. Now the important risk factors would be one, related to your lifestyle. Now obesity is one of the most important risk factor of colorectal cancer. Second would be lack of physical activity. Third, our diet, in which the increased proportion of your processed food and red meat intake. Now these are very strongly linked with colorectal cancer incidence. Another thing would be increasing prevalence of smoking and alcohol as well. There are certain families in which colorectal cancer can run by generation. So these are people who have genetic conditions like familial adenomatous polyposis or a condition like Lynch syndrome. Another risk factor would be people who suffer with inflammatory bowel disease, that is ulcerative colitis or Crohn's disease. So these are the patients who would have colorectal cancer at a higher incidence. Now anybody who has had colorectal cancer in past or who has polyp is also at a higher risk, and these patients will require special care and attention. So symptoms of colorectal cancers, unfortunately in very early stages there can be or there will be no symptoms, and that's actually true with most of the cancers. It doesn't give any symptom when it is just starting or it's in a nascent phase. Later on, the most common symptom would be blood in the stools. This could be a blood which is mixed with the stools or blood which is streaking the stools, or secondly, you can have blood after the act of defecation which would be separate from the stool. Now this is a very important symptom because many a times patients attribute these symptoms to piles or hemorrhoids and they will just trivialize it, which should never be done. Second important symptom would be a change in your bowel habits. Now somebody who's having change in a bowel habit could be you are increasingly getting constipated, or there is alteration in bowel habit. You are constipated one day and then you suddenly have diarrhea. Now in later stages, patients usually experience symptoms of anorexia and unintended weight loss. So any weight loss which is unintended is always a very worrisome sign. It should never be ignored. Even further, when cancer advances, patient can have pain abdomen, patient can have bloating, severe bloating and distension of the abdomen, and in last stages of cancer, patient can even can present with jaundice or pain in the back or bones, or at times there is some fluid retention in the abdominal cavity. So how do we diagnose the cancer of colon and rectum? So the gold standard would be a colonoscopy and taking a biopsy. We visualize the interior of the large intestine and then we take tissues or small samples and which are subjected for biopsy. Now this is the test which will confirm the presence of any polyp or any cancer in the colon and rectum. Once the diagnosis is made, the next step would be to stage the disease. So by staging we mean how far the cancer has spread out, if it is limited to the area where it has started from or it has progressed to other areas in the body. So staging is basically done by two methods. One is a CT scan or a PET scan, or CT scan of the abdomen or chest, or secondly a PET scan. In certain specific circumstances, like if you have cancer of rectum, we use MRI, contrast enhanced MRI, to stage cancer of rectum for local staging. In very rare circumstances, we might have to use some very special tests like endoscopic ultrasound for local staging. So there is a tumor marker called CEA, which is done for estimation at the base level, and then which is used for follow-up and follow-up of colonic cancer. So this is also an important test that we do during initial workup. So like all the cancers, even colorectal cancer has different stages. So there would be stage 1, when it just starts and it is localized to the wall of the colon, the initial internal layers. Stage 2 would be when it has involved the outer layers of the colonic wall, but it hasn't spread out to anywhere else. Stage 3 is a node positive disease where the cancer cells have spread to the regional lymph nodes. And stage 4 is when cancer has spread to the adjacent organs or distant organs of the body. That could be either spread to the lungs or the liver or to the bones, which can happen via either through your lymphatic channels or through your blood. So they are basically the 4 stages of colorectal cancer. So like any solid organ cancer, the propensity of cure totally depends upon whether you can perform surgery with a radical intent. That is, if you are able to get rid of cancer from the body entirely via surgery. If that is possible, you can achieve a cure for your patient. Now, treatment basically depends upon the staging of the disease. If patient comes to us in an early stage, say in stage 1 or 2, and also in some cases in stage 3, surgery is what is offered initially to the patient, and then depending upon stage, if patient is in stage 3 or stage 4, patient will require chemotherapy as an adjunct to surgery. So if a patient reports to us in a later stage of disease, say in a locally advanced stage or a stage 4 that is a metastatic stage, then this patient would require some sort of a pre-treatment in the form of either chemotherapy or radiation or both, and then we will subject them to surgery. Now, in earlier years, stage 4 colonic or rectal cancers, surgery was usually not performed or not offered. But nowadays, patient who has a colorectal metastasis to liver or to lung, or now even to peritoneum, these patients can be offered surgery with curative intent. Now, most of these patients will require some form of pre-treatment, like I said before, in either chemotherapy or radiation. Radiation is usually employed in rectal cancers. When you have lower tumors deep into the pelvis, we give these patients neoadjuvant radiation. The purpose of this is to sterilize that area. We reduce the bulk, which makes our surgery much more effective and much more easier, and it helps us in preserving the sphincters of patient much better. So when it comes to surgery for colorectal cancer, like I said before, it is the soul of the treatment of this disease. If you have to achieve cure, the limiting factor is whether you can achieve a surgery or removal of tumor with an R0 resection. So initially, historically, these surgeries were performed with open procedures in which we used to slice open the tummy and then reach to the intended area and take the tumor out. But in past couple of decades, technology have moved more and more towards a minimal access approach. So we have 2 techniques in minimal access. One is laparoscopic and second is robotic. So laparoscopically, what we do is we create small tiny keyhole size incisions, and through which we introduce the camera and working instruments, and then we perform the surgery exactly the way it should be done in an open procedure. Robotically, what we do is we take help of the robotic platforms to perform the same procedure. Now, in colon cancer and in certain instances in rectal cancer, the laparoscopic and robotic surgery has become standard of care, and in tertiary care center like ours, this is the most commonly performed procedure now. More than 90% of these surgeries are now performed via laparoscopic and robotic approaches. So what are the advantages of these minimal access surgery or its approaches? In long term, the results are as good as our conventional open procedures, but in short term, it has definite advantage. We have better cosmesis, we have less post-operative pain, we have early recovery in the form of early ambulation and early starting of enteral nutrition, and thereby the overall hospital stay shortens. So that increases the patient experience and patient recovery per se. Now, colorectal cancer is usually a very good biology disease. Most of the time we say when patient has a stage 4 cancer, it is usually end of the road. But this is not so in patients with colorectal cancer. Patient who has stage 4 colorectal cancer, in which patient disease has spread to either liver, lung, or even to the peritoneal surface, that is the inner lining of the abdomen, these patients can have very good, a very meaningful survival. Patient can survive for many years if they are given modern chemotherapy, immunotherapy, and if surgery is employed in a meaningful and sensible way. So prevention of colorectal cancer, almost 1/3 of all cancers are preventable. So what you can do as an individual to reduce your risk of getting this cancer? One, diet. So you should be predominantly on vegetarian based diet. Fresh fruits, green leafy vegetables which are locally produced is the best form. Secondly, processed food should be reduced as much as possible. The intake of red meat should be as little as possible. Regular physical activity, it's one of the most important thing and one of the most potent thing that can reduce your risk of getting cancer. Obesity, it should always be reduced. You should try to maintain a healthy body weight. Majority of cancers in some way are linked to either smoking or alcohol. So you should avoid using either of them. These are basic things that one can do to reduce the risk of getting cancer. Preventive part is a part. Other than that, we have some screening modalities. So screening for colorectal cancer. Now colorectal cancer is one of the very few cancers which are amenable for screening. Any person, seemingly healthy person, can be screened for colorectal cancer if he is more than 50 years of age. There would be a high risk patient population, people who have history of colorectal cancer in their family or who are suffering from inflammatory bowel disease, or patient who have some genetic predisposition. These patients will require screening at much earlier age and with much more frequency. Usually in a normal patient, if you do screening once in 10 years, it is sufficient. This can pick up very early signs of cancer or even before it has formed into cancer, and remedial actions can be taken. So my message to the audience would be that one, colorectal cancer is one of the commonest cancer in human body. Unfortunately, its incidence is increasing in India, but fortunately, it is one of the most amenable cancer to the treatment. If we give good treatment at right time, it can give very good and very long-lasting cures. Fourthly, you can reduce your chances of getting colorectal cancer by just attaining healthy lifestyle. Avoid smoking and alcohol and maintain good body weight with vegetarian based diet. Thank you.